Welcome to Anatomy Made Easy. I'm Dr. AmritaBharti. So let's start with the hand. As you all know that the hand is a highly evolved structure, isn't it? So we have the hand which can be used for the gripping, which can be used for many fine activities. It can be used for the tactile purposes, for touch reception, for temperature, and many fine actions, motor actions, and the fine actions can be done by the hand. So, when we see hand, first thing we consider is the osteology of hand. So, if you see it has a complex osteology, it has carpals, it has metacarpals, and it has phalanges. These are the carpals. Then you have the metacarpals, and further you have the phalanges. You can palpate these structures from the surface. Okay, so this is your surface landmark. This is known as the crease of the wrist. Okay, so if you see your hand, you have many creases in the hand because of the folding of the hand in the womb, right? So these creases develop because of this. Then you palpate, you have the bony prominences felt on the wrist. So what are these bony prominences? On the radial side, what you feel is the scaphoid. Okay, so this is the tubercle of the scaphoid that can be palpated. On this side, this is the medial side. If you see this bony prominence that is felt is your pisiform bone, right? Then you have the hook of the hamate, which can be palpated on the medial aspect. So these bony prominences can be palpated in a living individual. These are the carpals. So how do you remember the name of the carpals? So it is, she looks too pretty, try to catch her. So from lateral to the medial, right? So you have got two rows of arrangement of the carpals. This is the proximal row, this is the distal row. In the proximal row, you have scaphoid, lunate, triquetrum, and pisiform. Then in the distal row, you have the trapezium, the trapezoid, the capitate, and the hamate. So it is, she looks too pretty, try to catch her. This is how you are going to remember the name of the carpals. Okay. So you have two rows of carpals. You can see here. Then after this, we come to the metacarpals. When we see the metacarpals, we always number the metacarpals from 1, that is on the lateral most aspect. Okay, that is radial to the medial aspect. So this is the lateral aspect, this is the medial aspect. From lateral to medial, we have numbered the metacarpals as 1, 2, 3, 4, and 5. Then we have the phalanges. If you see in the first finger, this is the first finger, that is the thumb. Okay, we have only two phalanges. So these are the proximal phalanges, these are the distal phalanges. Whereas in all other digits, if you see, we have three phalanges. We have a proximal phalanx, we have a middle phalanx, and we have a distal phalanx, right? So this is the osteology of hand. Then coming to the palm of the hand, we have a palmar surface and we have a dorsal surface. On the palmar surface, if you see, there is this skin. It is very thick, okay, and it is very tightly adherent to the underlying structures. There are plenty of sweat glands present in this hand, and also you can see that there are numerous flexor creases which are formed. Okay? So these are the flexor creases which are developed during the birth process in the womb because of the flex position of the infant. Then coming to the papillary creases, you have certain creases which occupy the flexor surface on the digits. They have different shapes. All these creases that are present in the hand, what is the purpose of these creases? It is to improve the grip, to provide the friction, and also to provide roughness to this surface so that there is a proper gripping action possible. Then when we open the hand, when we start with the dissection, what do? We remove the skin layer. And just beneath the skin, there is this muscle which is known as the palmaris brevis. There is this palmaris brevis. What is this palmaris brevis? It is a subcutaneous muscle. That is just under the skin, you have a muscle which is attached to the skin. What are those subcutaneous muscles? They are nothing but they have the attachment with the skin. They do not have a bony attachment. So that is a subcutaneous muscle. And here we have the palmaris brevis. Coming to the different types of creases. Different creases have been given different names. Based on these creases, we have also different diseases which can be diagnosed on the basis of these creases. Okay. The longitudinal palmar creases. So they are one towards the radial side, which is a radial crease. This is also known as your lifeline. Okay, so this is your lifeline. Radial crease. Then you have a mid palmar crease. Can you see there is one line here? This is a mid palmar crease, which is also known as the line of fate. Then you have the transverse creases. Can you see these transverse creases? These are the transverse creases. So you have a distal transverse crease and you have a proximal transverse crease. When we flex our fingers, so when we flex these fingers, we have creases that develop due to the flexion. These are digital flexion creases. In this we have 4 creases medially, and we have on the thumb we have 2 creases, right? So on the medial aspect in these digits, we have 4 creases present from proximal to distal. Whereas on the thumb we have 2 creases present. In the wrist, if you see, again here we have 2 creases. Can you see this line? So normally we have 2 creases here. One is a proximal crease and one is a distal crease. The friction ridges. So friction ridges are nothing but the creases that are present on the digits, which are responsible for the friction of the surface of the palm, right? So they have different shapes. Some are loop shaped, some are whorl shaped, some are like the arches. Study of these ridges, it is known as dermatoglyphics. Okay, so these are important for your fingerprints and these are unique to an individual. So your fingerprints are unique to your individual and that is why they are studied for the dermatoglyphics, for forensic purposes, for medical legal purposes. Okay. Now we come to the dorsal surface. On the dorsal surface, if you see, the skin is very loose and it is loosely attached to the underlying surface. You have loose areolar tissue that holds the skin with the underlying surface. This is also the extensor surface of the hand and there is very little subcutaneous fat present. Coming to the palmar surface, if you see the palmar surface, there is the deep fascia. So there is a superficial fascia, okay, and there is this deep fascia that is present. The deep fascia of the palmar surface is modified to form flexor retinaculum, palmar aponeurosis, and fibrous flexure seats of the digits. Okay? So this is the modification of deep fascia in hand. Coming to palmar aponeurosis. The palmar aponeurosis, if you dissect this hand, it is the superficial most structure that you can see beneath the skin. It is a triangular surface. Okay? So you will see that there is a triangular deep fascia, thickened deep fascia in the form of a triangle, and this fibrous sheath has an apex towards the proximal end and the base towards the distal end. The apex is attached to the distal border of the flexor retinaculum and it receives the insertion of palmaris longus. So many a times it can also be said or it can also be written in some of your books that this is nothing but the continuation of the palmaris longus muscle that you have seen in the flexor compartment of forearm. So this muscle continues in the palm and it is thickened and widened to form a triangular palmar aponeurosis. The base of this palmar aponeurosis is dividing at the base of the fingers, the 4 fingers into 4 slips. So if you see here, these are the 4 slips. So the base has divided at this base of the fingers into 4 different slips. Each slips will divide into 2 bands, the superficial and the deep band. Superficial one passes to the skin and the deep one is present around the flexor tendon. So you see here we have the 2 bands in which these slips have divided, and the superficial one is adherent to the skin, whereas the deeper bands are going and they are winding around these flexor sheets of the digits. Okay, so they are attached over there. Now we see the medial border and the radial border. The medial border is continuous with the thinner deep fascia covering the hypothenar muscles. So this is the hypothenar muscle. This is the thenar muscle. Thenar group of muscles. We'll come to it later. So if you see this medial border of the palmar aponeurosis, this becomes continuous with the thenar group of the muscles. The medial palmar septum is what? It is the lateral border that becomes continuous with the thinner deep fascia covering the thenar muscles. So you see here we have a septum that is again becoming continuous with the thenar muscles. So this is your medial palmar septum. We have a lateral palmar septum. From each of these borders, there are fibrous septa which passes posteriorly into the palm in front and take part in the formation of palmar facial spaces. So we'll see this when we'll discuss about the palmar spaces. Okay, I'll explain this again when we'll discuss about the palmar spaces, how this palmar aponeurosis is sending the slips into to form the palmar spaces. Okay, so we have this palmar aponeurosis, the medial septum, and then we have the medial border. And also we have a lateral palmar septum which is sending slips on the flexor retinaculum, and it divides the underneath of the palmar aponeurosis into the facial spaces. Okay. The function is that it improves the grip, it provides attachment to the underlying structures, and also it provides attachment to the overlying skin. Okay. So that is the function of this deep fascia. Palmaris brevis. This is a subcutaneous muscle. It is an example of panniculus carnosus. Panniculus carnosus is basically the subcutaneous muscle that remains attached to the skin, and it has a function most prominent in the lower animals like your dogs, cats, cows, but in human beings it has become rudimentary. Okay, so what happens, like in the dogs and the cats, the skin is having attachment of the muscles. So if you throw a stone on the cow or a dog, what happens? Their entire body twitches. So there is the contraction of muscle in the entire part of the body, and then they will try to remove or shrug off the stone or any insect that is sitting on the body. So that phenomenon is known as panniculus carnosus, because of which the entire muscle is attached to the skin. Whereas this is only restricted in human beings in your neck region, in your palm region, that is in the form of palmaris brevis, and in the scrotum as the dartos muscle. Okay, so this phenomenon has become vestigial or rudimentary, or the remnant of panniculus carnosus remains in human beings restricted only to the neck region, which you have studied in the pectoral region as the platysma muscle. So you have the platysma muscle. Then in the palm you have the palmaris brevis. This is also an example of panniculus carnosus. Then in the scrotum you find a dartos muscle, which is the example of panniculus carnosus. Now we come to the origin of palmaris brevis. It is originating from the flexor retinaculum, okay, and the palmar aponeurosis. So it is a very short muscle. If you see, it is restricted only to your palm. Okay, it does not have a long attachment. It does not have a long course to travel. It is attached. It is taking origin from the flexor retinaculum, and it is attached on the skin of the palm. Okay, so it is a very short muscle. It is inserted along the skin on the medial border of the hand. Then we have the nerve supply is by the superficial branch of the ulnar nerve. The action of this palmaris brevis is to wrinkle the skin. Since it is attached to the skin, the contraction of this muscle will help in wrinkling of the skin, and obviously in providing it will provide the grip and it will also help in preventing the ulnar displacement of the hypothenar muscles. So it is present on the hypothenar aspect. This is the hypothenar aspect of your palm. Okay. So when you will dissect the hand, on this surface you will find the palmar aponeurosis just beneath the skin. This is the clinical aspect of the palmaris brevis and the palmar aponeurosis. So the localized thickening and contraction of this palmar aponeurosis results into dupuytren's contracture. It commonly starts near the root of the ring finger and draws that finger into the palm. Okay? So when there is thickening of this palmar aponeurosis, there is this flexion of the ring finger that starts. Then it may later involve the little finger also. So this type of presentation is there in the dupuytren's contracture because of the thickening of the palmar aponeurosis. Okay? So this is the applied aspect. Coming to flexor retinaculum, this is another modification of the deep fascia of the hand. This is the flexor retinaculum. It is nothing but a strong fibrous band. It also forms a carpal arch. It is attached on the carpals. Okay, so it is present on the carpals. It forms an osteofibrous tunnel. Osteofibrous tunnel means on the inner aspect you have the carpals, on the upper aspect you have the fibrous sheath, right? That is the deep fascia. So in between there is a tunnel. This tunnel is known as the osteofibrous tunnel. This is also known as a carpal tunnel. So the structures that pass through this carpal tunnel may get prone to compressions, and that symptom or that condition will be known as a carpal tunnel syndrome. So what is the carpal tunnel syndrome? Compression of the median nerve in the carpal tunnel is known as carpal tunnel syndrome. So why this will take place? Because whenever these structures, that is the nerve that is passing under the carpal tunnel or the osteofibrous tunnel, gets compressed, that is known as a carpal tunnel syndrome. Now this is important, the attachments of the flexor retinaculum. So this is the medial aspect, this is the lateral aspect. Radial is always, the thumb will always indicate the lateral. This little finger is always the medial. Okay? So coming to this lateral aspect and this little finger here, medial aspect. Medially, it is attached to the pisiform bone. Here is the pisiform. So it is attached to the pisiform and the hook of Hammett. Laterally, it is attached to the tubercle of the scaphoid and the crest of the trapezium. So this is a band of the fascia or a fibrous sheath that is extending on the distal aspect of your wrist. Okay? So the medial attachment it is on the pisiform and the hook of Hammett. Lateral attachment is on the scaphoid, that is tubercle of scaphoid and the crest of trapezium. So this thick band is known as the fibrous retinaculum. Okay, so we have seen two attachments. Now coming to the medial aspect, there is one slip that is going from here, and this gets attached to the third carpal, and this additional tunnel is formed here, which is known as a volar carpal tunnel. Okay? This is known as a volar carpal tunnel. So if there is the compression of the structure that is passing through this volar carpal tunnel, which is the ulnar nerve. So if there is compression of the ulnar nerve, this is known as a volar tunnel syndrome. Then ulnar nerve and the vessels passes deep to it. The deep slip is laterally present and on the medial lip of groove of trapezium, and you have the tendon of the flexor carpi radialis that passes through it. We'll come to the next diagram. So you see this diagram. These are the carpals. So this is your distal row of the carpals, right? We have the Hammett, we have the capitate. This is trapezium and trapezoid. Okay? So this is trapezoid and the trapezium. Now this is the facial tunnel that is formed. Okay? So we have the flexor retinaculum here. Now this is the lateral attachment, this is the medial attachment. Okay, here is a slip that is sent here. So this forms what? This is now the volar tunnel. This complete structure is a carpal tunnel. Okay, now the tendon that passes through this is what? Flexor carpi radialis. Okay, so this is flexor carpi radialis, whereas these are the tendons that are present of which muscles? Flexor digitorum profundus and flexor digitorum superficialis. So you can see the tendons of the flexor digitorum superficialis and flexor digitorum profundus passing through it. We have the median nerve passing deep to this carpal tunnel. So we have the median nerve, and we have the flexor pollicis longus. Okay, so these are the tendons that passes through the carpal tunnel, and this is the tendon that passes through the volar tunnel, right? So again, the same diagram can be seen over here. So any compression in this is known as the carpal tunnel syndrome. Now, what are the structures that passes superficial to the flexor retinaculum? You have a question on this. It can come as an enumerate question. So, the structures passing superficial to the flexor retinaculum are ulnar nerve, ulnar artery, the palmar cutaneous branch of the ulnar nerve, the palmar cutaneous branch of the median nerve, tendons of the palmaris longus. We have already seen that the palmaris longus comes here. It joins your palmaris aponeurosus. Then we have the superficial palmar branch of the radial artery, which forms the superficial palmar arches. Okay, component of the superficial palmar arches. So you can see the structures passing superficial. This is your flexor retinaculum, and these are the structures which are passing superficial to the flexor retinaculum. So this is the list of the structures. You have ulnar nerve, you have ulnar artery, you have the palmar cutaneous branches of the ulnar and the median nerve, you have the tendon of the palmaris longus passing above the flexor retinaculum, and it enters into the hand. Next, we have the structures passing deep to the flexor retinaculum. Now, the structures passing deep to the flexor retinaculum are these. So, what are these structures? Can you name them? Tendons of flexor digitorum superficialis, flexor digitorum profundus, then the median nerve, very important, and what else? Flexor pollicis longus. Okay. The tendon of the flexor carpi radialis, we have seen it passing through the separate canal, right? That is on the lateral aspect. So this is the flexor carpi radialis. Bursa is nothing but it is the synovial sheath. Okay, so this synovial sheath basically encloses the flexor digitorum superficialis and profundus muscle. Okay, so it will enclose the flexor digitorum superficialis and flexor digitorum profundus. This is the ulnar bursa. Coming to the radial bursa, what is the radial bursa? Radial bursa is the synovial sheath of the flexor pollicis longus, and it communicates with the common synovial sheath of the superficialis and the profundus tendon. Then we have the fibrous flexure sheaths of the fingers. If you come to the phalanges, okay, when you see the phalanges, they are ensheathed in the fibrous sheath, as if you have a tape tied around the entire structure. So this entire joint and the tendons that are passing through it, okay, which are entering into these fingers, what happens? They have been tied around by a tape-like structure, which is a fibrous sheath. So what is the purpose of that fibrous sheath? This fibrous sheath is actually holding the tendons in the position. So it is tightly holding these tendons in the position, right? So these are, on the flexor aspects, they are known as the fibrous flexor sheaths. On the extensor aspects, they are known as the extensor fibrous sheaths, right? So you see this finger, this is one digit, these are the phalanges, this is your proximal phalanx, the middle phalanx, the distal phalanx, okay. Here, these are the interphalangeal joints. So you have a proximal interphalangeal joint, you have a distal interphalangeal joint. These are the proximal interphalangeal joint. This is the distal interphalangeal joint. And this is the metacarpal. So you have the metacarpophalangeal joint here. All these are ensheathed by this fibrous flexor sheath. This is nothing but the modification of the deep fascia. Okay. So the purpose is to hold the tendons and the blood vessels in position and they do not get shifted during the movement of flexion and extension of these digits, right? This is a clinical condition known as the trigger finger. So what is trigger finger? Here the finger gets locked in full flexion. Okay? The extension occurs with a sudden click with voluntary efforts. It is coming with a sound, clicking sound, okay, when you try to extend these fingers. And this is because of the localized thickening of the long flexor tendons. So this is a clinical condition which is associated with the thickening of the long flexor tendons and usually present in the fingers, most common with the ring fingers.